cytomegalovirus. Properties belong to the beta herpes subfamily of herpes virus, double-stranded DNA enveloped virus, new capsid, 105 nanometer in diameter, 162 capsomes. The structure of genome of CMV is similar to other herpes virus, consisting of long and short segments, which may be oriented in either direction, giving a total of 4 isomers. A large number of proteins are included. For the precise number is unknown. Epidemiology. CMV is one of the most successful human pathogens. It can be transmitted vertically or horizontally, usually with little effect on the host. Transmission may occur in utero, prenatally or postnatally. Once infected, the person carries the virus for life, which may be activated from time to time, during which infectious virions appear in the urine and the saliva. The activation can also lead to vertical transmission. It's also possible for people who have experienced primary infection to be reinfected with another or the same strain of CMV. This reinfection doesn't differ clinically from reactivation. In developed countries with a high standard of hygiene, 40% of the adolescents are infected, and ultimately 70% of the population is infected. In developing countries, over 90% of the people are ultimately infected. Pathogenesis. Once infected, the virus remains in the person for life and may be reactivated from time to time, especially in immunocompromised individuals. The virus may be transmitted in utero, primarily or postnatally, prenatally or postnatally. Prenatal transmission occurs. Prenatal infection is acquired mainly through infected genital secretion. Breast milk. Overall, 2 to 10% of infants are infected by the age of 6 months worldwide. Prenatal infection is thought to be 10 times more common than congenital infection. Postnatal infection mainly occur through saliva. Sexual transmission may occur as well as through blood and blood product and transplanted organs. Clinical manifestation. Congenital infection may result in cytomegalic inclusion disease. Prenatal infection usually asymptomatic. Postnatal infection usually asymptomatic. However, in a minority of the cases, the syndrome of infectious mononucleosis may develop, which consists of fever, lymphadenopathy, splenomegaly. The heterophil antibodies test is negative, although atypical lymphocytes may be found in the blood. Immunocompromised patients, such as transplant recipients and AIDS patients, are prone to severe cytomegalovirus disease, such as pneumonitis, retinitis, colitis, and cephalopathy. The activation or infection with CMV is usually asymptomatic except in immunocompromised patients. Congenital infection, defined as the isolation of CMV from the saliva or urine within 3 weeks of birth. Commonest congenital viral infection affect 0.3 to 1% of all live births. The second most common cause of mental handicap after Down syndrome, and is responsible for more cases of congenital damage than rubella. Transmission to fetus may occur following primary or recurrent CMV infection. 40% of chance of transmission to the fetus following a primary infection may be transmitted to the fetus during all stages of pregnancy. No evidence of teratogenicity. Damage to the fetus results from destruction of the target cells once they are full. With cytomegalovirus inclusion disease, CNS abnormalities, microcephaly, mental retardation, spasticity, epilepsy, periventricular calcification, eye, choreo, retinitis, choreo, retinitis, optic atrophy, chorioretinitis, and optic atrophy, ear, sensorineural deafness, liver, hepatosplenomegaly, and jaundice, which is due to hepatitis, lung pneumonitis, heart myocarditis, thrombocytopenia purpura, hemolytic anemia, plus sequelae in individuals symptomatic at birth, hearing defects, and reduced intelligence. Incidence of cytomegalovirus diseases. This is the incidence in USA and UK. Laboratory diagnosis, direct detection. Biopsy specimen may be examined histologically for CMV inclusion bodies or for the presence of CMV antigen. BB65 CMV antigenemia test is now routinely used for the rapid diagnosis of CMV infection immunocompromised patient. PCR for CMV DNA is used in some centers, but there may be problem with interpretation. CMV BB65 antigenemia test. Laboratory diagnosis, virus isolation. Conventional cell culture is regarded as a gold standard, but require up to 4 weeks of result. More useful are rapid culture methods such as DEF test, which can provide results in 24 to 48 hours. Serology, the presence of CMV IgG antibody indicates past infection. The detection of IgM is indicative of primary infection, although it may also be found in immunocompromised patients with reactivation cytopathic effect of cytomegalovirus. And this is cytopathic effect on tissue culture. Their test for CMV. Centrifugation culture, fixed and stained 16 hours after inoculation, showing viral protein in nuclei of infected human fibroblast cells. Specimen for laboratory diagnosis, urine, saliva, blood, tissue, and the serology IgG, IgM, neonate, urine and saliva in adult, urine and blood, pregnant woman, and the immunocompromised patient can take from urine, from saliva, from blood, from tissue. Treatment congenital infection. It's not usually possible to detect congenital infection unless the mother has symptoms of primary infection. If so, then the mother should be told of the chance of her baby having cytomegalovirus inclusion disease, and perhaps offer the choice of an abortion. Prenatal and postnatal infection. It's usually not necessary to treat such patients. Immunocompromised patients, necessary to make a diagnosis of CMV infection early and give prompt antiviral therapy. And CMV agents in current use are ganciclovir, foscarnet, and cidofovir. No licensed vaccines available. There is a candidate live attenuated vaccine known as clone strains, but there are concerns about administration a live vaccine, which should become latent and reactivation. Prevention of Cmv disease in transplant recipient is a very complicated subject and varies from center to center. It may include the following measures: screening and matching of CMV status of the donor and the recipient, use CMV negative blood for transfusion, administration of immunoglobulin, give antiviral agent. Epstein-Barr virus belong to gamma herpesvirus, subfamily of herpesvirus, nucleocapsid 100 nanometer in diameter with 162 capsomer. Membrane is derived from by budding of immature particles through cell membrane and is required for infectivity. Genome is a linear double-stranded DNA molecule with 172 kilobytes. The viral genome doesn't normally integrate into the cellular DNA but forms circular episome which reside in the nucleus. Genome is large enough to code for 100-200 proteins, but only a few have been identified. Epidemiology. Two epidemiological patterns are seen in Epstein-Barr virus. In developed countries, 2 peaks of infection are seen. The first is very young preschool children aged from 1 to 6, and the second in adolescents and young adults aged 14 to 20. Eventually, 80%-90% of adults are infected. In developing countries, infection occurs at a much earlier age, so that by the age of 2, 90% of the children are seropositive. The virus is transmitted by contact with saliva, in particular through kissing. Pathogenesis. Once infected, a lifelong carrier state develops whereby a low-grade infection is kept in check by the immune defense. Low-grade virus replication and shedding can be demonstrated in epithelial cells of the pharynx of all seropositive individuals. Epstein-Barr virus is able to immortalize B lymphocytes in vitro and in vivo. Furthermore, a few Epstein-Barr virus immortalized B cells can be demonstrated in the circulation, which are continually cleared by the immune surveillance mechanisms. Is associated with Epstein-Barr virus is associated with several very different diseases where it can act directly or one of several cofactors: disease association, infectious mononucleosis, Burkitt's lymphoma, nasopharyngeal carcinoma, lymphoproliferative disease, and lymphoma in the immunocompromised, X-linked lymphoproliferative syndrome, chronic infectious mononucleosis, oral leukoplakia in AIDS patients, chronic interstitial pneumonitis in AIDS patients. Infectious mononucleosis, primary Epstein-Barr virus infection is usually subclinical in childhood. However, in adolescents and adults, there is 50% chance that the syndrome of infectious mononucleosis will develop. Infectious mononucleosis is usually a self-limited disease which consists of fever, lymphadenopathy, splenomegaly, and some patients jaundice may be seen, which is due to hepatitis. Atypical lymphocytes are present in the blood. Complications occur rarely but may be serious: splenic rupture, meningoencephalitis, pharyngeal obstruction. In some patients, chronic immunomononucleosis may occur where eventually the patient dies of lymphoproliferative disease or lymphoma. Diagnosis is usually made by heterophil antibody test and or detection of IgG. There is no specific treatment. Burkitt lymphoma occur epidemically in parts of Africa where it's commonest childhood tumor, and Papua New Guinea. It usually occurs in children aged from 3 to 14 years. It responds favorably to chemotherapy. It's restricted to the areas with holoendemic malaria. Therefore, it appears that malaria infection is cofactor. Multiple copies of Epstein-Barr virus genome and some Epstein-Barr virus engine can be found in BL cells, and patients with BL have high titer of the antibodies against various Epstein-Barr antigens. Burkitt lymphoma shows a reciprocal translocation between the long arm of chromosome 8 and chromosome 14, 2, and 22. This translocation results in C oncogenes being transferred to the immunoglobulin gene regions. This results in the degradation of the C-Myc gene, so that this translocation is probably already present by the time of Epstein-Barr infection and is not caused by Epstein-Barr virus. So for the cases of Burkitt lymphoma occur especially in AIDS patients, which may or may not be missed. Nasopharyngeal carcinoma. Nasopharyngeal carcinoma is a malignant tumor of the squamous epithelium of the nasopharynx. It's very prevalent in South China, where it's the commonest tumor in the men and the second commonest in women. The tumor is rare in most parts of the bone. The tumor is rare in most parts of the bone. Pocket occur in N and C Africa, Malaysia, Alaska, and Iceland. Multiple copies of Epstein-Barr virus genome antigen can be found in cells of undifferentiated nasopharyngeal carcinoma. Immunocompromised patient after primary infection of this Epstein-Barr virus then a state low chronic latent infection in body. Should the person become immunocompromised, the virus will reactivate. In few cases, lymphoproliferative lesion and lymphoma may develop. These lesions tend to be extranodal and in unusual sites such as GIT tract and CNS. Transplant recipient, renal. Epstein-Barr virus is associated with development of lymphoproliferative disease and lymphoma. AIDS patient. Epstein-Barr virus is associated with oral leukoplakia and with various non-Hodgkin lymphoma. Duchenne X-linked lymphoproliferative syndrome. This condition occurs exclusively in males who have inherited a defective gene in X chromosome. Diagnosis: acute Epstein-Barr virus infection is usually made by the heterophil antibody test and detection of the anti-Epstein-Barr virus IgM. Cases of Burkitt lymphoma should be diagnosed by histology. The tumor can be stained with the antibody to lambda light chain. Case of nasopharyngeal carcinoma should be diagnosed by histology. Determination of the titer of anti-Epstein-Barr virus screening is early lesion. A patient with non-specific ENT symptoms who have elevated titer of Epstein-Barr virus should be given thorough examination. Vaccination against Epstein-Barr virus, which prevent primary Epstein-Barr virus infection, should be able to control both PL and NPC. Such vaccine must be given early in life. Such as vaccine would also be useful in seronegative organ transplant recipients and those developing severe IM, such as male or offspring of X-linked proliferative syndrome carrier. The vaccine should not preferably be a supplement vaccine, since there is a danger that a vaccine may still have tumorigenic